रंजन सर नमस्ते।
Nice to see you promptly being there, Yogesh.
Yogesh, in the meeting only since 4 o'clock.
Much appreciated.
It was the government meeting was there 4 to 5:30
Uh-huh.
in doing the work.
Hello, Dr. Ilin. I can see you logged in. How are
Yes.
you? I'm Dr. Anita.
Thank you. Thank you.
I think it's time. It's 4 o'clock. We'll get
Yes.
started.
Sure,
Okay.
sure.
Let me make my introductory invite to IAP dignitaries and we will get started. Good evening and welcome everyone for this session of IAP AMH CME. It gives me great pleasure that we have reached 1 year mark and it's our 1 year anniversary. This is the 12th session. For people who are logging in for the first time or a brief introduction, we are from American Mission coordinating with the Indian Academy of Pediatrics to deliver monthly subspecialty CME in pediatrics. And we have covered various subspecialties thus far. And here we are for the 12th session. Our subspecialty today's discussion would be sleep medicine. Uh, we have a change of plan this time. We always do it on the fourth Sunday. For some logistics reason, we did change. And thank you all for noting the revision and the timings and logging in for today's session. We have Dr. Yogesh and Dr. Ranjan, the people behind the whole concept of IAP AMH collaboration and our CMEs. I would like to invite them to give a brief forward to what our plans have been so far, and we will get started with the CME after that. Dr. Ranjan and Dr. Yogesh, please, I'm glad you could sign in today, and please uh, update our audience about our success story, and then we'll proceed from there. Dr. Ranjan and Dr. Yogesh after that. Dr. Ranjan, please.
Um, Good evening to everybody. As Dr. Manita has mentioned, we will be completing the first year with this meeting. It is the initiative of American Mission Hospital and Indian Academy of Pediatrics to have these webinars. Uh, Dr. Salman, Dr. Vanita have been very, very instrumental in keeping this meeting punctual and well attended. Dr. Yogish has shown his commitment to this meeting. I
Dr. You muted. Dr. You
see
got
the
muted.
as well as the speakers, and we have covered all the important subspecialty. Uh, is less discussed but very important, even as far as the public is concerned and the general pediatricians are concerned. More of it should be known, and then we'll be able to manage our children even better, I'm sure. So, thanks to the speakers, Dr. Eileen and Dr. Ranjit Peters. Um, for your valuable time to participate in this meeting. I think I'll stop here and I hand over the floor to our popular General Secretary of IAP,
Yeah.
Dr. Yogesh Parikh.
Thank you, Dr. Ranjan Pejawar sir, for the kind words. And thank you, Dr. Vanita Madam and Dr. Mohammed Salman for contributing a lot for this IAP Bahrain and AMH webinar. And this is our 12th webinar and a very important topic today. We have selected the sleep medicine in the pediatrics. And we have a wonderful expert like Dr. Ilin Kinimi and Dr. Ranjan Peter for this excellent CME today we have. And we heartily congratulate to the team and thanks to all this platform who join on this today's program webinar. Let us, without wasting any time, let us hear the experts, Dr. Kinimi and Dr. Ranjit. Please over to you, Dr. Vanita. Please carry forward this program.
Thank you, Dr. Yogesh and Dr. Ranjan. At this point, I would like to acknowledge the great contribution of Dr. Ranjan in handpicking each subspecialist for our CMEs and high quality CMEs that we have had thus far. I am Dr. Vanita. I'll be your moderator for today's session. Today, as I introduced already, the theme is sleep medicine in pediatrics. We have two eminent speakers from their parts of the world, Dr. Ilin from India and Dr. Ranjit from Bahrain. As people who are familiar with our design of CMEs, we will have coordination between the local problems and the global situation so that the guidelines are updated for the practicing community. So today, sleep medicine, not a very common encounter, yet commonly encountered. We will see how we need to appraise ourselves in this concept, and Dr. Ellen will cover what is meant for. We had a brief discussion as to what will appeal to the pediatric practicing community in this subspecialty. And Dr. Elaine was asking me what would be the topic she should be covering and what's the kind of audience that she would be addressing. So she chose this topic so we can be assured of highlighting ourselves as to the current consensus of what we are supposed to know. So the theme is sleep medicine in pediatrics. The area directly impacts various aspects of a child health, right from growth, behavior, probably neurocognition, and many overall well-being of a child. And we will see how we can update ourselves regarding this. And it will be followed up by the structural aspects of sleep disturbance would be the purview of ENT specialists. And then we are privileged to have Dr. Ranjit Peter, who would be covering the ENT aspect of it. I will introduce his topic after introducing Dr. Ellen Penny. So the first topic is pediatric sleep issues, which will be covered by Dr. Ilin Kinemi. Dr. Ilin Kinemi is a pediatric pulmonologist from Bangalore. She is practicing currently in Manipal Hospitals, Bangalore. She has acquired a fellowship in pediatric pulmonology and sleep medicine from NUH Singapore. That's how I pronounce National University Hospital, Singapore, I believe. Diplomate ERS, Pediatric Respiratory Medicine. So over to you, Dr. Elaine. The topic could be pediatric sleep medicine. The next half an hour is yours, and we are waiting to get enlightened by you for this topic. Thank you. Please take over, Dr. Elaine.
Thank you so much, Dr. Vinita, for for your kind words and your introduction. I'll just get to getting my slides in order. Thank you, Dr. Ranjan, for introducing me to the team and the IAP. I'm really honored to be here today, and I hope I can do justice to the topic that's been given to me. So basically, sleep disordered breathing, right? And we'll start with one case. It's a typical case that you and I have seen in our OPDs. The 7-year-old boy, he's snoring and mouth breathing for the last 2 years. His restless sleep has been observed. He wakes up groggy and tired. He has features of allergic rhinitis for the last 6 months. So he's runny, itchy, sneezing almost every day. He had an episode of wheeze, which he received some nebulizations. He's gaining weight adequately. So this is our boy here. So pretty much we can see that this boy is having issues with his sleep, right? So we go on to take a detailed sleep history. And in the sleep history, obviously he's having these nighttime symptoms, snoring, mouth breathing. You could see that he could probably be having probably some pauses in his breathing with that kind of severity. He assumes abnormal positions. He's quite restless all over the bed. He has issues of bedwetting and restlessness. Daytime, he's really tired. It's difficult to wake him up, and he is beginning to get aggressive. And the school has also called the parents that he is not doing so well in his academics. So when we examine him, he has an allergic shine. He has malaligned teeth because of this mouth breathing, perhaps, flat mid face, high arched palate, tonsils, as you can see, that are quite large, grade 4. His ears are normal. His chest examination is normal. When an X-ray is done, it does show an adenoidal enlargement. For a nasal endoscopy, this child was not cooperative. So we went on to do a sleep study, a level 1 sleep study, which showed an AHI of 13, which predominantly with obstructive hypopneas and apneas, and this is a severe OSA. Started on inhaled corticosteroid nasal spray on antihistamines, and an ENT review was done. There was no improvement in 6 weeks despite the inhaled corticosteroids and the antihistamines. And as per the ENT advice, adenotonsillectomy was performed. His symptoms gradually improved. So this is case scenario 1. The second case is a 10-year-old boy who has Duchenne's muscular dystrophy diagnosed at 3 years of age. He's on oral steroids. He's wheelchair bound since the last 7 years, since he turned 7. He has a rapid weight gain, obviously with the steroids and with this kind of immobility since the last 1 year. He is also now progressive scoliosis of the last 6 months. When you look at his anthropometry, he's obviously growing well and is well above his centiles. When we look at his sleep history, he's snoring at night, he has mouth breathing. Daytime, he seems to be coping up well, goes to school. But when we do the sleep study, what's remarkable is here 176 events, which includes obstructive events and a lot of hypopnea events, right? And this is 176. This is way beyond normal. When you look at his carbon dioxide levels, he begins to really have like early morning 47, 46, even touching 49. His CO2s are high. So he's obviously hypoventilating as well. And remember, in this child, there's not much of daytime symptoms, and he's just that he has become wheelchair bound on steroids and obese. So what we do is we started an NIV support of BiPAP, physiotherapy, his spine referral for scoliosis, and a bone health check. And we had to do check for pulmonary hypertension because he had a severe OSA. And we had advised a titration study in 6 months' time. So this is the 2 case scenarios. But let's go back to basics. So during sleep, what happens? Our muscles in our body relax, including our oropharynx. So our airway starts narrowing. In the supine position, there's even reduction in the lung volume. And during REM sleep, the rapid eye movement sleep, the deep sleep, our drive to breathe is decreased. Our tone of the entire body decreases, and paradoxically, our upper airway resistance doubles, and there are tidal volumes and respiratory rate variability during this phase of sleep. Even though our body is in deep sleep, we are having issues with our tone, with our airway resistance. So when we talk about sleep disordered breathing, it's a spectrum, right? It's a spectrum of several conditions in which there may be partial or complete cessation of breathing, and this occurs at night. It leads to a fragmented sleep, impacts our gas exchange, our carbon dioxide buildup, our oxygenation, impacts our quality of life, and includes obstructive and central problems that may come with or without hypoventilation. Why do children snore? Are they different from adults? Definitely they're different. So they have anatomically narrower pharyngeal airways. There's increased collapsibility of the pharynx. And the children that are at risk are obviously with enlarged adenoids and tonsils, obese, those with facial anomalies or abnormalities, and of course, tone issues, hypotonia. So when you look at this, you can see that when we are breathing normally, we have a fantastic airway. But with any partial obstruction, this obstruction can be anywhere from the nose, palate, uvula, pharynx, any of this pathway, if it gets obstructed, we have a child who will snore. And with a complete obstruction, there is a lot of compromise on this airway, and these children have severe OSA. But what is obstructive sleep apnea? So, this is an upper airway dysfunction because of this partial or complete obstruction during sleep. It results in arousals in the brain or desaturations, and it can affect and anything affecting this upper airway diameter or the integrity of the upper airway can contribute to this OSA. So, anatomical factors, genetic syndromes, neuromuscular issues, and this OSA particularly peaks between 2 to 8 years of age. What are the causes? Simple OSA can be because of the adenotonsillar hypertrophy, obesity. The complex ones with apneas and hyperventilation because of various craniofacial syndromes like Apert, Cruzon, Pfeiffer syndrome, Down syndrome that we so commonly see, neuromuscular problems, and obesity syndromes like Prader-Willi, Bardet-Biedl, and Pair-Robbins sequences. So this is roughly a simple as well as the causes of simple as well as complex OSA, and even conditions like achondroplasia. So what is this sleep disordered breathing causing to our system? So we are eventually having mouth breathing. This mouth breathing can also lead to anatomical changes, high and narrow palate, abnormal orofacial growth. It can cause changes in the position of the tongue or low position tongue. Allergen stimulation can worsen it, and there's a local inflammation that can also increase. And of course, this all produces the typical enlargement of the adenoids and the tonsils. So a child with mouth breathing will have eventually land up with enlarged tonsils and adenoids, as well as this will again cause mouth breathing. All these factors interplay, and what leads us to any changes in the orofacial growth can also cause nasal disuse, and then this again worsens the nasal passages, so the child has poor nasal breathing and of course increased upper airway resistance. And this spectrum leads to the sleep disordered breathing, which has many effects, particularly a systemic inflammatory state. So, adverse effects can affect various systems. So, when you talk about cardiovascular morbidity, it can be prolonged, it can cause hypertension, autonomic dysregulation, endothelial dysfunction, neurocognitive effects of ADHD, depression, aggressiveness, learning behavioral issues. We have growth failure, either failure to thrive or obesity, and metabolic effects of insulin resistance and metabolic syndromes. So it doesn't stop there. So we need to understand what are the long term sequelae of a child with OSA. So, why is this important? Why do we need to recognize? With treatment, the decreased sleep fragmentation and decreased arousals, you have a child with better quality and quantity of sleep, improvements in your behavior, improvement in attention span, better growth, and in so many cases we see reversal of pulmonary hypertension, improvement in all our inflammatory markers and other physiological parameters. So it is a thing that we can recognize early and be able to prevent the sequelae that follows with it. How do we diagnose? So we can look at history, sleep logs, pediatric sleep questionnaires, polysomnography. But first, the history. We have to ask for symptoms like snoring, is the child breathing, or is the abdomen and the chest moving in opposite directions or moving very rapidly, retractions, mouth breathing, neck hyperextension. Some children can't sleep straight or in a certain positions, apneas or just pauses, gasping, restless sleep, and even nocturnal enuresis. Daytime sleep symptoms of just very not a good sleep, difficulty waking them up, very moody child, hyperactive, irritable, and excessive daytime sleepiness. So we need to ask about what's the duration, how frequently, what is the degree of problems. So it may be a short term or a long term problem. So we need to understand that. Sleep schedules, please look into it. What's the sleep wake time? In weekends, the child is sleeping too much or too late. In the weekdays, sleeping too little, too early, or too late. How many hours per night? What are the naps the child is taking? How frequently waking up at night? How much time does the child take time to fall back off to sleep? What does the child do to get back to sleep? Are there any environmental disruptors while sleeping? Does the child really have a bedtime routine? So very important, these are the questions of sleep hygiene. Other than that, last meal consumed, some children are eating very late, caffeine intake in the adolescents, or some energy drinks, the excessive screen time and physical activity is very poor in some of these kids. So when you look at the physical examination, obviously, what do you observe? Mouth breathing, adenoidal facies, any kind of dysmorphism, change in the voice or hyponasal voice, tonsillar size. Look for any changes on the jaw, the retromagnetia or micrognathia, macroglossia, signs of any pulmonary hypertension like a loud P2, assess tone, especially in young babies. So a normal child, you may not need to look for all these extra features, but in a child that has syndrome or any craniofacial anomalies, or we need to also watch out for what else is there in a child who's coming with a sleep apnea. There's a bare screening test which assesses what are the bedtime issues, any excessive daytime sleepiness, awakenings during the night, any problems with the regularity and duration of sleep, any sleep disordered breathing or snoring. So this is a very basic questionnaire that can be accessed. It's available online as well, and it's just a yes and a no. Any questions that any of these answers that you have a yes, you need to check if there are red flags and assess further. A sleep diary, again, it's a subjective assessment of sleep. You take a 2-week record of the child's daily sleep routine and sleep related activity. It's a simple, inexpensive tool, very easy to implement in your OPD and useful in understanding the sleep patterns, because sometimes as parents we forget how a child's sleeping pattern is, but limitations that are that it is subjective. We may be over or underestimating the sleep pattern. So this is a typical 2-week sleep pediatric sleep diary. You put in the days, the dates, and you mark is the child awake or sleeping, how many hours per night. So it's a very simple way of having just a brief view of what is happening in the last 2 weeks of a child. So you can give it to parents and they can fill in the log and get back to you. There are other questionnaires like the PSQ questionnaire, OSA score, OSA 18, but remember that these have low diagnostic accuracy, and you also you use it especially to assess the impact on the quality of life, which is also important and useful as an adjunct as you treat a child. There's also something called a EP, Epworth sleepiness scale for children and adolescents, 12 to 18 years. A child is excessive sleepy. We take a score of more than 10, suggests excessive daytime sleepiness, more than 16, then we need to do something really urgently. But let's go back to investigations. How do we investigate a child where you have OSA or you're suspecting OSA? You want to confirm the diagnosis, you want to evaluate the upper airway. So the best tests are a sleep study. Either you do an overnight oximetry or a cardiorespiratory sleep studies or a full PSG. For upper, you can also include carbon dioxide measurements, either transcutaneous or end-tidal. Upper airway, extranasopharynx, any CT, MRIs, nasal endoscopy, and DICE. Overnight pulse oximetry. So it obviously you're using this oxygen desaturation as a surrogate marker for obstructive event. It is important to use the right type of oximeter, and those oximeters must have an averaging time of 2 to 3 seconds. It has a great specificity of 98%, but the sensitivity is poor. And we also uh, calibrated using the McGill's oximetry scoring system, where you look at how many episodes the child is saturation less than 90, less than 85, less than 80, and there's a scoring method to see how severe this child may be in terms of the obstructive events. It has its own advantages that it's simple, easy, parents can do it at home, you can screen patients with it, perhaps low cost, good positive predictive value. It's home based, so it's more comfortable. But remember, it is not going to measure your airflows, your hypopneas, and your apneas. There may be too many movement artifacts, and a child with severe OSA may not still have desaturations despite of everything. So we have to be very careful in interpretation. This is a typical overnight oximetry. You can see the oxygen saturation in green and the heart rate in red. And there is a way of looking through these results and interpreting the results. Next, we come to cardiorespiratory studies. It has limited channels. You can do it at hospital or at home. But remember, any home testing for children is usually not the best, right? And it consists of a video camera, chest and abdomen bands for respiratory effort using plethysmography. You have some airflow measurements using thermistors or nasal cannula. You're checking heart rate, oxygen saturation, and the carbon dioxide levels. It allows us to differentiate central and obstructive events and also can quantify the degree of hypoxia. But remember, we have no EEG scoring on this, so we do not pick up arousals, and therefore we may underscore the hypopneas. So it has everything basically except the EEGs, and we may still miss out a lot of events because of this. So this is typically what if you look at this, it shows these two channels are for snoring. Sorry, I'll start from here. This shows the saturation events. This shows the heart rate. This shows the carbon dioxide. This is showing your snoring pressures, your snoring. These are the pressure flows, basically your cannulas that you've put on the nose. These are all showing the thorax and the abdomen movements. You can see these movements that are more or less synchronous. You can check the saturation, the pulse, as well as the carbon dioxide and the plethysmography. So this is a typical cardiorespiratory study, and this does not show any EEGs. Polysomnography is the gold standard. It's supervised by personnel and it's performed in a dedicated sleep tech by the technicians. You want at least 6 hours of data. It includes, so if you see this young boy here, he has some EEG electrodes, he has EMG on his chin, he has eye electrodes. We have just covered that, but that measures his eye movements, a pulse oximeter for his saturation. There is a electrode for his heart rate, ECG. There are these two bands, thoracic and abdominal bands, which are measuring the movements, and there are nasal cannulas and thermistor. Here we've put a mask on this child, but there are cannulas that are put on the nose. There's a video camera as well as a microphone there on his neck, and we also check the carbon dioxide level. If it's an end-tidal or if it's a transcutaneous, it's like a patch that we put on the forearm. So what do we measure in the PSG, right? There is a criteria, and we most commonly use the AASM, the American Academy of Sleep Medicine criteria for scoring. And it tells you we have to know how many of these events are obstructive or central, and how many of these are obstructive apneas or obstructive hypopneas, likewise central apneas or central hypopneas. all we need to do is calculate this index called the apnea-hypopnea index. So this is the total number of events, be it apneas or hypopneas, over the number of hours of sleep, and then we get an index. So this is a PSG showing all the leads. So if you start from the top, these are the eye movements, the green. Then after that, all these are EEG electrodes right till here. So we have about 4 sets of electrodes here. Then we have the EMG that is usually put on the chin. Then we have the ECG leads. Then we have the snoring mic. Then we have these are again the flows that are being measured through your thermistor or your nasal cannulas, the flows. Then the red line here is the oxygen saturation, then your pulse rate. This is your plethysmo, this is the body movements, and this shows what position the child is sleeping, on the right, on the left, and these are your thoracic movements, right? So this entire montage is basically all the leads, all the events that we're recording on a level 1 polysomnography. So how do we grade the severity? So if it is an AHI of 1 to 4 is a mild OSA, 5 to 9 is moderate OSA, and severe is more than 10. It's definitely different from the adult scoring. In addition to AHI, we look at something called the desaturation index. How much is the hypoventilation, that's the carbon dioxide, any sleep fragmentation or arousals that are measured on the EEG. There are various challenges to pediatric PSG. The limited availability, accessibility for everyone, the high cost, it depends on a good sleep tech. It's time consuming to do it and to read it, specialized equipment and expensive equipment. Sometimes there are long waiting lists. There may be night to night variability, especially in kids. And a lot of children have the first night effect when they are thrown into a new environment. They may not sleep well. And it's as it is, the sleep, the test is challenging, and then when you put a child in a new environment, it may be even worse, and the child may not even get enough sleep in that one night. Briefly on upper airway, because the next speaker would also be speaking on it, we always ask for a lateral x-ray to check for the adenoids, but remember, it is a 2D imaging technique, interpretation depending on the position of the neck, and also inter-observer variability is there. CT is really too high a dose to radiate a child. MRI, longer scan time, cost, and just difficulty in getting it done in a child. There are other cine MRI or dynamic MRI, but which may provide 3D images, but again, expensive. All centers don't have it. Nasal endoscopy, easily done in our OPDs, assesses the dynamic airway obstruction, where is the obstruction, the level of obstruction. It's pretty simple, easy, reliable, provided you have a trained expert, but it requires cooperation, and in children, it can still be challenging. Newer modalities like drug-induced sleep endoscopy, you're visualizing, you put a bronchoscope or the endoscope at different levels, and you check where is the level of obstruction. You're giving minimal sedation, useful particularly in those children with residual OSA after adenotonsillectomy. And if used prior to a surgery, we also can plan the surgical intervention maybe better or tailor it. Disadvantages, of course, patient is sedated, your airway dynamics may not be truly representing what's happening at night. You're putting in an airway in a child that already has a small airway, so it produces a lot of resistance and pressure changes. And of course, it may even alter the site that you're looking at, right? The site of obstruction. Then let's come to the treatment, right? The treatment of simple OSA. Medications, we all know intranasal steroids, allergen avoidance, weight loss if a child is obese, surgical interventions wherever needed, adenotonsillectomy, CPAP, BiPAP therapy when there's no surgical treatable lesion or the surgery is contraindicated. Medical therapy is warranted in mild OSA. We do a trial of at least 6 weeks of once daily intranasal steroid. Most commonly, we use mometasone or fluticasone. Sustained effect is 2 months after discontinuation of the drug, up to 2 months after discontinuation of the drug. Montelukast may or may not be used in conjunction, but we have a lot of problems using Montelukast for too long. And sometimes obese children and those with older age may still benefit from a trial of the medical therapy. Complex OSA, as I said, it's syndromic. It has many other things that we need to deal with, and we need to assess and treat the underlying etiology, know what the etiology is first before going on straight away to do anything. And if there is a child that has hypoventilation with this complex OSA, then we need to start non-invasive ventilation. So the referral pathway for all of us, it involves our general pediatrician, our developmental pediatrician who see ADHD and extremely restless kids or kids falling academically or having some learning issues, an endocrinologist who would see all the obesity syndromes or just simple obesity or various syndromes, a neurologist that sees hypotonia or neuromuscular issues, a geneticist that has picked up a case very early, for example, a child with SMA or many of the neuromuscular issues, an ENT specialist that gets the referrals for the adenoids and the tonsils or some airway obstruction, the spine team with the scoliosis, particularly, especially in those with neuromuscular scoliosis. So we need to recognize. We can always screen using the various sleep logs, sleep diaries, sleep questionnaires, but ultimately, you have a good pediatric sleep team. We can do much more, and wherever needed, the polysomnography and the NIV wherever indicated. So in our lab, we have just put in these indications, respiratory indications for sleep study includes adenotonsillar hypertrophy, any of those hypoventilation with obesity, the various genetic syndromes, MPS or achondroplasia, any of the central apneas, neuromuscular disorders. There's a huge list of so many chronic lung diseases like PBT, even cystic fibrosis. When you suspect sleep disordered breathing, we call them in also for titration, even prior to tracheostomy decannulation, cerebral palsy, or children with global development delay can also be referred for the sleep studies. And non-respiratory indications, even though it's rare, periodic limb movement in children, um, children those with narcolepsy or hypersomnia, children with frequent parasomnias, nocturnal enuresis, and some rhythmic movement disorders. So even in these, we can always, depending on how the history or the severity of the condition, we can plan a polysomnography in these children. So I'll end my talk here and yeah.
Thank you, Dr. Ilin. That was very comprehensive and clinically addressed, and it seemed like it was extremely tailor-made for our purpose and the theme of pediatric IAP CMEs. We will have a joint Q&A session after the next speaker. I urge the audience to post the questions in the chat box so that we can take up the questions, keep the questions brief so that we have more time for discussion. And we will follow up the next speaker and with the Q&A session. So that leads to the next session to Dr. Ranjit Peter. We got a brief overview of what are the kind of problems we encounter in pediatric sleep issues. Structural happens to be one of the chunk as highlighted by Dr. Ilin. So when it's structural problems, specifically adenoids and tonsils, it's the purview of ENT specialists. So we are lucky to have an ENT specialist covering our topic with the same focus, Dr. Ranjit Peter. Dr. Ranjit Peter is an ENT surgeon who's currently practicing in King Hamad American Mission Hospital. He will be talking about post-adenoidectomy OSA. So something specific, which would be essential for pediatricians to know. So Dr. Ranjit, please take over. the next
Thank you,
30
Dr. Vanitha.
minutes. And we will have
Dr.
the
Vanitha, can I
Q&A
just
after
have your
this.
confirmation? Am I audible?
Yes, doctor.
Yes. Okay.
Very clear.
And is the screen clear? Is my
It
presentation
is.
on?
It
Yeah,
is.
yeah.
Yes, doctor.
So thank you very much, the entire team of the Indian Academy of Pediatrics, and especially Dr. Vanitha for coordinating. And thank you, Dr. Ilin, for the excellent coverage of the medical side of things. And I can assure you that I will not be overlapping on anything that she shared so that you don't sleep off. And I really thank the entire IAP team. And of course, I bring you greetings from the American Mission Hospital. Just a minute, please. I just get this out of the way. Hold on. Okay, all right. Yeah, okay, right. So I have no disclosures to make. And this session, I plan to, the next half an hour, I plan to go about in this way. I will highlight what is the common practice in the general practice that happens in the pediatric clinics or the ENT clinics. What generally happens when it comes to a patient with OSA. And after that, we'll dive right into the topic of the persistent obstructive sleep apnea, which the topic that I've chosen. And we'll look at what are the contributors for that, what is the current evidence for that, and we'll look at how to redefine our approach or refine our approach when it comes to pediatric OSA as well as persistent obstructive sleep apnea. And we'll look at also the multidisciplinary care that is required across colleagues, across specialties. And I will summarize finally. That will be what we would do in this session. And the target audience, of course, are pediatricians, ENT surgeons, and general practitioners, because we need to raise the awareness. So I'm going to go into not a case scenario, but I'm going to go into a common occurrence that happens in our daily practice. So imagine this, the parents of a child come to us, whether it be an ENT surgeon or whether it be to the pediatrician in a busy clinic, and they come with the classical symptoms that were mentioned by Dr. Ilin earlier. They have snoring, mouth breathing, and struggling in bed, not being able to sleep well, maybe nocturnal enuresis, and daytime sleepiness, daytime restlessness, sometimes hyperactivity, and all the classical symptoms of what we would think of as obstructive sleep apnea. And as Dr. Ilin mentioned, we take a lateral radiograph, or sometimes we do a nasal endoscopy, flexible scopy, and as we would expect, we would see some amount of gross grade 4 adenoid hypertrophy with some tonsillar hypertrophy as well, obstructing the airway. And sure enough, it's work as usual, and proceed on to post the patient for surgery. And in the clinic, this is an 18-month-old child. I want you to listen, if it's audible, listen to his sound. You can hear the classic mouth breathing and even the gurgling sounds. This is the daytime, so imagine what happens at night. And so this patient goes on for an adenotonsillectomy by whatever be the technique that is used with whatever are the instruments available, whether it's a dissection method or like today's fancy, we use the coblator. Again, there are techniques for coblator. We do the complete extracapsular tonsillectomy, which is the removal of the entire tonsil. I'm going to fast forward that. And we have a very neat, fossa at the end of the day. Or we have the more, contemporary, what we practice nowadays is the intracapsular tonsillectomy, which is just removing the hypertrophic part and leaving behind the capsule so as to reduce the postoperative pain as well as decrease the incidence of, postoperative hemorrhage. So this is the intracapsular tonsillectomy. The reason I put this forward is there is a relevance when it comes to this talk. So this is intracapsular tonsillectomy. And we would go ahead and do the adenoidectomy again with the coblator under endoscopic vision, removing the entire adenoid tissue with the coblator. So everything goes well, and that's the end of the adenoidectomy. You can see the fossa. Everything goes well, and 2 months post-operatively, you can see the child is breathing to the mouth. Breathing with the mouth closed, and it seems to be comfortable. Now, this is what happens in most of the situations. However, in about 20%, 10 to 20% situations, of course, we'll look at the statistics later. Sometimes parents do come back and tell us that, the child is still snoring. There's still some amount of struggling happening. I know, doctor, you remove the adenoids and tonsils, but still the child is struggling. And this would qualify as a persistent obstructive sleep apnea, which is not diagnosed yet. And sure enough, at this point of time, there may be other people who come with expert opinions, like maybe alternative medicine specialists who come and say, we told you that adenotonsillectomy is not going to solve the problem. Or others may come and say, I told you not to go to that doctor, and so on and so forth. All kinds of opinions from family members would come, and the parents are stuck, and they just probably live with it and go on, proceed in life. So diving into pediatric OSA, the global prevalence of OSA is about 1 to 5%. In the GCC, from various literature sources, in the GCC, snoring is at about 10%, OSA is about 2 to 5. Indian statistics, snoring, the urban population, in urban children is about 8 to 10%, and OSA is about 2 to 4%. However, when it comes to overweight children, that number increases to 25 to 45%. And when it comes to obese children, the number increases even more to 60%. So imagine that 6 out of 10 obese children having OSA. Now let's dive in straight to the topic that we are discussing about persistent obstructive sleep apnea. I'm going to call it POSA, not DOSA, POSA. Persistent obstructive sleep apnea, which is by definition obstructive sleep apnea after adenotonsillectomy, or obstructive sleep apnea that occurs after tonsillectomy when the adenoids are not enlarged. In other words, adenoids have not even been addressed because the adenoids were never enlarged in the first place. And the global prevalence of persistent obstructive sleep apnea is at about 20 to 40%. And obese children, again, as you can imagine, the obese children, as though nothing happened, even though the adenoids and tonsils were removed, nothing happens, still remains at 40 to 60%. So these are some very interesting articles, and I've just put this QR code so that in case you want to refer, these are some recent articles which are really, really good, which gives a very good overview and of the entire situation. This is, of course, from one of our journals, from the American Journal, outlining the head and neck surgery. This is the expert consensus statement on management of pediatric persistent obstructive sleep apnea after adenotonsillectomy in 2023. This is, of course, from our pulmonology colleagues, the management of persistent post-adenotonsillectomy obstructive sleep apnea in children. This is again from 2023. And this is an excellent article from our Italian colleagues, again, pulmonologists and the pediatrics department. 3 decades of managing pediatric obstructive sleep apnea syndrome, what is old and what is new. And this article, in fact, does a very good overview of almost A to Z about the entire situation, including persistent obstructive sleep apnea and how to go about managing. And in fact, there's an logarithm and all of that. So that's about some articles. And based on this, I want us to take you to what are the main contributors to persistent obstructive sleep apnea? Why does it happen? Why does it persist? As Dr. Ilin mentioned, allergy is, of course, a lifelong thing, and allergy persists. And allergy also means there's a lot of nasal congestion and inflammatory process happening. And so that is, of course, there. Obesity, the soft tissue collapse, and so on. Syndromic children and craniofacial anomalies, there's many times retrognathia and even crowding, especially Downs, for example, this crowding of the upper airway and the oropharyngeal airway. Now, when it comes to this, now I am going to use this slide about maybe 2 or 3 times in my presentation. The reason I put that is because this is that important. So what I'm proposing and what I'm suggesting is when a patient comes to us with what seems to be a very clear-cut case of adenotonsillar hypertrophy causing obstruction, or whether it's the apneas or hypopneas or PSG proven, with a very high AHI, it is important to keep our eyes and ears open to what is the phenotype of the child. Is it just lymphoid hypertrophy, adenotonsillar or lingual hypertrophy? Sometimes missed. The lingual hypertrophy is many times missed. Is the child obese? Does the child have craniofacial anomalies, or are there any associated neuromuscular problems? And many times, as in today's age, the mobile phone driven age and the sedentary lifestyle age, with obesity on the rise, it is very common to have a mixture of many of these conditions together. It's not just one condition at a time, and you know that allergy is always on the rise. So the reason I'm putting up this slide is it's very important that you don't take things for granted, that we don't take, oh yes, the adenotonsillar hypertrophy is responsible for everything, so everything's going to be all right if we remove the adenoids and tonsils. It's very important to look at the whole scenario. And as Dr. Ilin mentioned, the obstruction can be at any site, from the nasal valve, the turbinates, the adenoids, the soft palate, the base of tongue, lingual tonsils, epiglottis, and so on. And then there's another, data collection for persistent obstructive sleep apnea. It's found that almost 70% happens at the nasal level and about 66% at the tongue base level. So let's go into how to approach these scenarios, especially I'm talking about pediatric OSA, how to approach. Why do I say that? Because if we warn the parents sufficiently in advance that this is the entire picture, and we do expect additional help even after the removal of the adenoids and tonsils, because we're talking about the entire picture. As Dr. Ilin mentioned earlier on, the symptoms are very important. Now, I'm not going to go into the symptoms, but all I want to highlight here, I'm not going to read these symptoms because I'm sure pediatricians are experts. But what I mean to say is the symptoms are very specific many times when it comes to infants. It's probably a little different for the toddlers. It's different for the preschoolers, and it's different for the school-going. That's what I want to highlight. I'm not going to read these symptoms, and I'm sure the pediatricians are very, very familiar with all the symptoms. Questionnaires, yes. The questionnaires, we don't generally use them, but however, in the ChatGPT-driven world where parents have their only children and precious children and pampered children, they many times are taken aback if we don't give them questionnaires. So questionnaires are many times not routinely given, except for maybe obesity clinics and specialized clinics, but it is a good idea to have, to quantify and to record the severity of the condition. So when it comes to assessment, it is important to assess clinically. And when I say clinically, I'm not speaking about just the radiograph. I'm talking about the moment the patient walks in, look at the patient, look at the facial features, facial profiling, look at the dentition, malocclusion, high arch palate, and so on and so forth, and look at the posture and overall picture. And then, of course, radiograph, if it's done, yes, it is done in case we don't do the laryngoscopy, the fiber optic scopy. Generally, most children, even as young as 3 years old, if counseled properly, do agree and consent and are managed to agree for a flexible scope because the scopes are not exactly large. We have pediatric, we have 2.7 mm scopes, which go in easily, and if they are counseled enough, they do agree for that, and that gives us a better picture. However, having said that, sometimes, in today's world, insurance demands that, the scope is not sufficient. They need an X-ray radiograph. And so sometimes we are forced to do a radiograph, though we don't need it. Earlier, Dr. Ilin mentioned about the dynamic MRI and cine MRI. Now, I would put that with a word of caution because we are speaking about children who have not yet proven OSA or persistent OSA after a procedure. So we're talking about children who can desaturate very quickly. And unless the MRI radiology section is really equipped with a standby team for desaturation, it's not a very wise idea. Even if it's affordable, even if it's possible, feasible, plausible, it's not a very good idea to go ahead with a cine MRI as a part of evaluation, simply because the risk involved is too high. Then, of course, coming to drug-induced sleep endoscopy, where I will spend some time and I will tell you exact indications. Is it really indicated for everybody, or is it for somebody alone? So I'm again bringing down to the phenotype. So please do remember the phenotype when we do the assessment regarding the obesity, regarding is there any craniofacial anomalies. Sometimes they don't have any, it's not a syndrome. It's just the familial feature. You look at the child and look at the father and mother. They have the same nose, the same facial features. And the father has a small retronatia. And the same thing happens in the children. So it may not be a syndrome sometimes. It's just facial features. And that's enough to cause OSA. I want to introduce this topic. I'm sure some of us are familiar, but this concept of coupling. Why do I say coupling? Because it becomes such a big deal when it comes to OSA. Coupling is this phenomenon where the tongue gets sucked in and gets attached to the roof of the mouth and allowing good nasal breathing. Now, this becomes important when it comes to the changes that happen because of adenotonsillar hypertrophy or upper airway obstruction, because of mouth breathing, and as Dr. Ilin mentioned about the changes in the mid-face that happen, the crowding and the malocclusion, the high arch palate that develop because of the negative pressure. So there is a loss of coupling. You can see the CT scan. You can see the tongue is in the roof of the mouth. Now look at this CT scan with a high arch palate. You can see there's this gap between the tongue and the roof of the mouth. And there is loss of coupling. And what happens when there's loss of coupling? The tongue is going to fall back. And tongue falling back is going to cause a definite obstruction in the airway. And that brings me to polysomnography. Now, again, Dr. Ilin dealt with very well about polysomnography, including the interpretation and so on. So I will not go into that. But my point being, when do we do polysomnography? Do we do for every child? Do we do a polysomnograph for every child who's going to undergo a tonsillectomy? No. So we would do an we would do the scoring and polysomnography in specific indications. We would do if there is obesity, there is Down syndrome, craniofacial anomalies, sickle cell disease. Why sickle cell disease? Because sickle cell disease, they do have a lot of lymphoid hypertrophy all over the place. Mucopolysaccharosis. And if there is sleep disorders breathing with normal or small adenoids and tonsils. So if it's a regular child with an hypertrophic adenoids and tonsils as a primary setting, we don't do polysomnography. First of all, it's not available freely everywhere. Secondly, it's not indicated. So if the phenotype dictates, yes, go ahead. Or if the adenoids and tonsils are small, go ahead. Or if there's persistent OSA after adenotonsillectomy, go ahead. So what is the consensus? The consensus is this. Routine pre-op sleep monitoring for surgical decision-making is not recommended in children without comorbidities, especially if they are above 2 years of age. And when severe OSA is not suspected. Pre-op sleep monitoring should be considered for children less than 2 years of age for pre-op planning. Pre-op pulse oximeter sleep study may be considered for children without comorbidities with suspected severe OSA, and preoperative sleep monitoring for all ages with comorbidities. That is the phenotype that I mentioned. What alternatives we have? It has been found that just a half an hour home video recording, all our parents have phones with mobile, with the cameras, with the HD cameras, 4K cameras, and just a 30-minute video of the sleep, it has been found, there is evidence that the sensitivity is as high as 94%, specificity is of course 68% for screening for OSA. There is this watchpad test, the watch peripheral arterial tonometry. Again, the diagnosis of pediatric OSA, it has been found has got high specificity for diagnosis of severe OSA. Awake nasopharyngeal laryngoscopy is a very, very beautiful, evaluation, because you see the entire thing, and especially when it comes to lingual tonsils, which is missed by just an X-ray or by regular routine clinical examination. The lingual tonsils are seen on flexible scope. Now coming to drug-induced sleep endoscopy, which is again, something that we would not do in every single situation. There are specific indications. When would you do a drug-induced sleep endoscopy? We would do a drug-induced DISE if there's persistent OSA after adenotonsillectomy, and if there's OSA without adenotonsillar hypertrophy, or OSA with the phenotype that I mentioned, significant comorbidities. So these are situations where we would do. And in how do we go about it? We, of course, again, Dr. Ilin mentioned about it. I will just go straight into the classification. Now, again, when it comes to classification, there are several kinds of classifications. We look at various levels, the velum, the palate, the oropharynx, tongue base, and the epiglottis. And then when it comes to children, we add the adenoids as well. Now, again, we classify into the kinds of collapse: anteroposterior, lateral, concentric collapse, and of course at the velum level, at the oropharynx level, at the tongue base level. And there's a scoring pattern where we give a 0 for no obstruction, 1 for partial obstruction, and 2 for complete obstruction. Now, when it comes to DISE, I want to bring this topic, this entity called the sleep-dependent laryngomalacia. Sleep-dependent laryngomalacia is a very interesting entity described by Amin and Isaacson in 1997, where the patient has absolutely normal breathing while awake. However, when they typically go into the N3 stage of sleep, they have stridor and increased work of breathing. Now, this is a DISE. You can see this is at the palate level. You're looking from the nasopharynx. You can leave the soft palate. Now, this is the base of tongue here, and you can see the epiglottis flapping back and causing an E2, which is a complete blockage. Now, in such a patient, if you were to give PAP therapy, they are going to have worsening of everything. So DISE has a definite role in the situations that I mentioned earlier. So how do we go about counseling, and how do we go about managing these patients? As Dr. Ilin mentioned earlier on, a multidisciplinary care is the key, and it is not just routine work as usual. It requires focus. It requires, preemption. It requires counseling. Even this morning, I had a patient, who was obese, and I did an adenotonsillectomy. But I made it a point to tell the parents, the child has a high arch palate, crowding our upper teeth. The snoring is not going to go away by just adenotonsillectomy. That, you will need additional help from orthodontists and the maxillary expanders and so on. So when it comes to the medical management for, persistent OSA, intranasal steroids, either fluticasone furoate or mometasone furoate, for at least 3 months is the recommended period. And again, there are recommendations for leukotriene receptor antagonists like Montelukast. But as we know, Montelukast comes with a black box warning of behavioral changes, and especially in syndromic children or in obese children, we must be careful, because anything more than 3 months can cause problems. And the recommendation is only for maximum of 12 weeks, that is 3 months. And if we do give a warning and we inform the parents if we are giving Montelukast that, watch out for any behavioral changes, and if so, you may stop it immediately. Obesity management has to go side by side. That again requires multidisciplinary care. And in the team that Dr. Allen mentioned, you saw the dietitian involved. DICE-guided adjunctive surgery. When it comes to POSA, that is persistent obstructive sleep apnea, has to be a DICE-guided adjunctive surgery that is done. Now, we all are familiar, the age-old, the dictum that, septoplasty or any septal work has to be delayed up to 17 or 18 years of age till the growth is complete. However, there is current evidence, and it's reasonably very good evidence, that pediatric septoplasty can be done safely. If there is a significant blockage, a pediatric septoplasty can be done safely. Of course, we don't go ahead and do any radical procedure. It's just limited septal cartilage work. We don't gouge out any bone or remove any bone. It's just the deviated portion endoscopically done without touching any growth centers. So it is done safely. And in today's day and age, we have techniques of avoiding nasal packing. And so it can be done very safely. Inferior terminoplasty, again, is something, sometimes children, especially with allergy and persistent allergy and who don't respond to steroid nasal sprays, who have large terminates. And sometimes we do have patients with large adenoids, grade 4 adenoids, and completely blocking terminates. So in such situations, we would go ahead and reduce the terminates as well so as to give them a good nasal airway, because otherwise they're not going to improve. Lingual tonsils, of course, if in persistent obstructive sleep apnea, lingual tonsils need to be addressed. Many times, lingual tonsils can block the airway completely. And when there is, a floppy epiglottis, which is blocking, it will need to be addressed, especially in infants with severe laryngomalacia causing severe OSA and so on. Respiratory support, non-invasive ventilation. Again, Dr. Allen mentioned about CPAP, AutoPAP, and BiPAP, and especially BiPAP would be required for children with neuromuscular problems and who cannot manage themselves. High flow nasal cannula is a very good option because it, as you know, the compliance in PAP therapy is very poor. And again, especially when it comes to children, long-term PAP therapy has been shown to cause some amount of mid-facial hypoplasia. And so that becomes another concern. So these are all concerns. And we must, especially in a high arch palate, when there's a high arch palate with crowding upper teeth, the dictum I follow is I ask the parents to wait for maximum of 6 months to 1 year and proceed with the orthodontic or craniomaxillofacial consult. However, remember that the mid-palatal suture fuses at around 12 years of age. So if the age is close to 12, then might as well proceed directly post removal of the adenoids and tonsils to go ahead with an orthodontic consult. And they would put in a rapid maxillary expansion device, which expands the mid-palatal suture and improving coupling and increasing. Remember that the roof of the mouth forms the floor of the nose. And if the roof of the mouth is narrow, the nasal floor remains narrow. And so you are able to achieve a widening of the nasal floor by widening the mid-palatal suture and the hard palate. So that is something that happens over time, and that does make a big difference. Mandibular advancement devices, specifically in specific conditions, this can sometimes be a good option for relieving the base of tongue from causing blockage. We must not forget this entity called myofunctional therapy. Myofunctional therapy is again something that must be advised and counseled and offered. And this is something over a period of 6 months, there is evidence of reduction in the AHI with that. And of course, the future, we know of the hypoglossal nerve stimulation that is in fashion in the US. In India, of course, it is many times very expensive. Um, and as you know, this is meant for adults. However, the US FDA has made a concession, has made a provision for 13 years and above Down syndrome children to be offered hypoglossal nerve stimulation because they believe that after 13 years, the growth of that area is almost complete and there's not really much that needs to be done except for probably the change of battery that needs to be done after some time. So that is something in the pipeline. So what is the take-home message? My take-home message is this, that pediatric OSA and persistent OSA is a multifaceted, serious, complex condition. It must not be taken lightly. It must not be taken for granted. Interdisciplinary collaboration and cooperation is a must. We must not think of it as, one thing does everything, or one person can deal with everything. It doesn't happen. In today's world, we must use the help of each other and other disciplines. High index of suspicion and leading questions are the key. This is very, very important, especially things like the sleep induced laryngomalacia. You saw the one in N3 sleep. Those kind of things are picked up many times by just asking for specific questions and getting a video. Of course, it's not very common, but we will not miss. Early diagnosis, intervention, and follow-ups are important. It's not enough if we just treat and leave them. Even if they are, dissatisfied, or even if the problem is not solved, they must have the confidence to come back to us and tell us so that we can proceed with the PSG and if required, a DICE, and then look at what is contributing to the problem. Individualized management strategy is important. One size doesn't fit all. It must be individualized. ENT evaluation for static and dynamic obstruction must be assessed and dealt with. Thank you for your patient hearing, and I believe this is the time for questions. I go back to Dr. Vanitha. Thank you.
Thank you, Dr. Ranjit. That was very valuable insights to top up Dr. Ilin's presentation. So, from both the talks, we have gathered a lot of information as to where we belong as pediatricians regarding these issues. So, let us check on some questions to enhance some more discussion points with the speakers. As I see, there are some thank yous and some asking about CME certificates. There's one question from Dr. Rashu Mittal. How often this is to Dr. Ilin, how often do you order sleep studies in uh, pediatric group?
Okay. Yeah. Thank you for that question. And so basically, again, that question is depending on where you are, right? So, but because we have a level 1 sleep lab with a transcutaneous, and especially I've been in this field for the last 15 years in this hospital. And we were probably the first hospital in Bangalore to start the pediatric sleep studies. And by default, we've become a referral center. So on an average, we are doing about 14, 15 sleep studies per month, which is quite a big number. And the reason also being, apart from the typical, the enlarged tonsils, adenoids, we also see a lot of our neuromuscular patients that are referred to us just for their regular sleep screening as well as titration. So because of that large base, we have a large number of studies. And I think my colleague, Dr. Ranjit, very well pointed out that every child need not go for a sleep study, especially before a TNA. There are certain categories that you need to do a pre-op evaluation or even a post-op evaluation as the POSA cases. So according to that, our cases are a mixed bag, and we do more because it's become a referral center.
Thank you, Dr. Ilan. So, for practicing pediatricians, what's your message as to when would you expect referral from them? what is the point? We did see the common indications and such. Just a brief overview of the red flags, which they shouldn't miss, and seek your further involvement in management. So, if you can just highlight on certain red flags and messages to our practicing pediatricians in this connection. I see some more questions. Uh, can you elaborate on the exercises which can be used to treat? This is to Dr. Ranjit. And what are the criteria for referral? Again, there's Dr. Mohammed asking, what are the criteria for referral of a child with OSA to ENT? Should we investigate or we will expect ENT evaluation in toto? So, Dr. Ilin, give us
Okay.
a new
So I
update of
will answer, yeah, the part one, and then Ranjit can answer the second part. So to
yes.
basically to put it very simply, I did highlight what are the nocturnal symptoms that this child is facing, what are the daytime symptoms. So like the first case that I said, the child was having snoring, mouth breathing, he was having restless sleep, and on that was the day night issues. He was also beginning to have a nocturnal enuresis, and in the day he was being picked up for academics suffering. He was getting restless, moody, aggressive. So these were all the red flags, and typically these are the red flags that we need to check what's happening. And of course, the first thing I would do is, of course, take a good history, understand what's happening, any comorbidities like the allergic rhinitis we manage, and then if there is an element that you think that there's a tonsils and adenoids involvement, definitely it requires a ENT review. And then the ENT and the two teams can decide how to proceed further. And like Dr. Ranjit pointed out, it is like really an interdisciplinary team effort. And more we begin to realize that, as Dr. Ranjit also pointed out, the POSA is so huge. The number of cases, like 30 to 40%, are coming back to you saying, we're not getting better. The child was better a little bit after surgery, but the symptoms are back. But this is also because of our lack of understanding and our lack of counseling that brings back these patients with more frustrations, more questions, and them changing the doctor. So I think this is a really big balance that we have to hit when we are sending the children to ENT. And every child that has a suspected OSA, we need not necessarily do a PSG, but remember one thing: the sleep study may also not corroborate with the clinical findings, and vice versa. And depending, does this child have comorbidities, the obese, the Down syndrome, the syndromic kids, the neuromuscular? Those children, again, the pattern is different. So our referral to the ENT would be at various levels, and that really is an understanding between the two teams.
Thank you. That sounds great. Dr. Ranjit, there is a question for you.
Yes. Yeah.
If you can
About the
elaborate on the
exercise. Yes.
exercises.
Yeah.
Yeah.
Yeah. So the exercise, myofunctional therapy is not something new. It's been there for a very, very long time. I mean, not for a long time. It was started off by the Japanese, who started it off. And basically, the tongue exercises for the adults, what we do is we ask them to do these exercises, if I may use these steps, push the tongue against the roof of the mouth for 10 seconds and do that multiple times, about 10 times. Hold it stiff against the roof of the mouth, trying to touch with the tongue, trying to touch your chin, like that. Hold it like that for 5 seconds. Trying to touch your nose, trying to touch your chin, to the left, to the right. Then doing this one, the rolling your tongue, and holding like that. Then clicking, doing the clicking sound, and holding a spoon and pressing against the spoon with the tongue. These are all exercises which we give adults. The similar exercises are there for the children, and many times this is actually if you really contact your speech therapist, they have handouts of these. They have handouts of the myofunctional therapy, and many places they do actually physically do it for children. And it comes to babies, or when it comes to little children, parents are taught how to do it physically, putting their finger in their mouth and moving the tongue and so on. There are physical exercises that are recommended for children. So these are myofunctional therapy, and it is not a one-day thing. We are talking about at least 6 months. 6 months of myofunctional therapy for oromotor exercises, which help with reducing the AHI. So that again, there is literature on reduction of AHI following myofunctional therapy. So this is something that can be done. It is not very difficult, and I'm sure there are sufficient resources. YouTube videos, we sometimes give we send forwards to the YouTube videos which are available by physiotherapists and speech therapists. So that forms a very good guideline or guidance to the parents when we are counseling regarding myofunctional therapy. Hope that answers your question. I will dig in, and I will also go ahead and, if I may, there's a lot of overlap. So to the question which was directed to Dr. Ilin, when do you refer a patient with OSA to ENT? If I may take the liberty. So generally, the patients may come to the ENT or may come to the pediatrics first. And I'm sure as pediatricians, you will be seeing more. So as we know, when we suspect adenotonsillar hypertrophy, especially adenoid hypertrophy alone, we would give a course of, as is the current guideline, we would give a course of intranasal steroid sprays for at least 2 months. And if there is persistent blockage, then of course, I believe the patient should come to ENT to have a look. And as you know, we do not believe in taking X-rays every now and then because it's radiation. We would recommend taking an X-ray, a lateral radiograph, after 2 months of steroid nasal sprays, so that we know what is the residual adenoid tissue. And even in ENT side, as far as possible, we try to avoid the X-rays. We do a flexible scopy to assess real-time the size and the grade of the adenoids, not just the adenoids, even the turbinates for that matter, lingual tonsils and so on. So it works at tandem. ENT and pediatrics works at tandem, and I believe we should refer to each other. And there is definitely a role for assessment by an orthodontist as well as a dental department for especially looking at the mandible. And the maxilla, because like I said, a high arch palate, many of the children, they would have had so many different recommendations from different places, and they would have put off surgery and put off intervention for so long that they come with a high arch palate, crowding teeth and all malocclusions and everything. So they need parallel widening of their maxilla, the roof of the mouth. So it all is one thing. And so we must develop that team concept where multidisciplinary care is provided. I hope that answers the questions.
It does. Thank you, Dr. Ranjit. Dr. Ilin, would you want to add your inputs on that?
No, I think
When would you?
yeah, I think we have pretty much covered both our bases, I would say. And yeah, I think it's all like personalized. It can't be one size fits all. Every child is different, like different age, different, categories. So we have to be cautious in handling each child that has OSA. I think that's the most important thing, that we cannot just be shooting X-rays. We cannot be randomly doing things. And because the sequelae to all this is what will bring the child back, and it's not really a pleasant situation when you're faced with very frustrated and angry parents who have not found the solution to the problem that they actually came in for. I think that's really, really important to understand.
Yes,
and if I may add, the sequelae to all this is in the form of behavioral problems in adulthood,
Yeah.
divorces, and social problems in family, social problems at workplace, and violence and all that, suicidal tendencies, all that. It's all a part of missing out on managing at the pediatric level. They grow into adulthood and they end up with divorces and all kinds of problems. Yeah.
Thank you. Dr. Ilin, I noticed that you mentioned certain screening tools. What would you recommend for a busy pediatric OPD? What's the screening tool you would recommend?
I think the
said
bears is the
bears.
bears is one of the most commonly used and most commonly because it's very easy. If a parent is just sitting outside, you can just it doesn't take time to do it. So I think that's a good screening tool and most commonly used also, I think.
Yeah, and when would a pediatrician trigger a polysomnography from a sleep specialist?
When
It's
would you
your
recommend?
decision, is it?
When would
When
you
would we think of doing the polysomnography or further evaluation when Bayer's screening is
yeah, so it
suggesting something
yeah.
for us?
Yeah, so it gives you like, the all the parameters that are there, it would be a yes or a no, right? So let's say the child is excessively sleepy at night, or his sleep timings are irregular or frequent awakenings. So those modalities once ticked, there is a certain, so any of those can serve as red flags. And for you to say, okay, this child needs a little bit further evaluation. And it's
Evaluation.
not necessarily you have to go straight to a sleep specialist. I think you will when you score that, you will know that there is this child having a problem. It may not be sleep apnea. It may be that the child has just irregular sleep patterns, or having a problem with the quality of sleep or the quantity of sleep, right? So there are many things that you can just pick up quickly and then evaluate. For an obstructive sleep apnea, for a polysomnography, you just have to know, okay, if this child is having all those nocturnal symptoms, the daytime symptoms, those would be the red flags that I had already mentioned.
Okay, thank you. There are a couple of questions, although not related to OSA, about role of melatonin and in sleep issues. What's
Your
your
take on that?
suggestion? What's your take? How? Yes,
Yeah.
the duration. When would you stop, and when? Uh,
So yeah.
just a brief overview. Yeah.
Yeah, so melatonin is basically it's a hormone that we're giving to induce sleep, right? It is basically something that helps the system to say, okay, it's time to sleep, or it's like a switch, right? So we will not be giving it to children who are having OSA typically. We are going to give children with the circadian like the day night. Let's say a child has been in the ICU for too long, the day night cycle has shifted, or a child with cerebral palsy and seizures and development delay having a problem in the sleep wake cycle shift. Those typically are the kids that they're awake the whole night and they're sleeping the whole day. When we're not able to get that shift, that is when we would recommend melatonin. It has to be given at a very minimal dose at the outset, given at least maybe half an hour, 60 minutes before the actual like sleep time. And we do a trial for, let's say, 4 to 6 weeks and understand, okay, is this working or not? We don't keep these children on melatonin very long. And it has you have to use it very judiciously. I think I rarely have given it, and the most common times that I've given it are the children that have been in the ICU for very long, and then they come out and their sleep cycle has been disrupted. Yeah, typically, or the children with developmental issues, the cerebral palsy, global development delay. Those are the kids that require this. Extreme cases of jet lag.
Okay. Thank you. Both the speakers refer to Montelukast, the black box warning, Montelukast and the side effects and the last 5 years, there has been quite a lot of talk about it, and different strategies have been implicated on practicing pediatricians as to how to go about Montelukast. So one of the strategies Dr. Ranjit mentioned is give it for 3 months and then withdraw it and observe. But it's more idiosyncratic within a day or two also. They've noticed these. So in your respective practices, what is the side effect profile? Is it as much hype as it's been made out on? Have you encountered many Montelukast adverse effects, and how is your practice on it? I would want the input from both the speakers there.
Yeah, so Monte Lucas, basically, I have seen kids literally after a few days, the child sleepwalking, some behavioral issues, extreme moodiness, even some kids sleepwalking. And so, in my practice, I rarely use Montelukast, to be honest. And it's really in extreme situations that I'm pushed to it. But I have seen too many kids having this problem, perhaps also because we are dealing with all the allergic kids, all the children with this recurrent cough and cold issues, and they come to us. I mean, for us, it's really the bread and butter of what we practice, right? So, having seen so many kids having so many of these problems, I really, really am very, very mindful of using it. And if at all, it would be like for a few weeks. I don't think I have exceeded much more than that in my practice. And that is only because I have seen a lot of kids suffering from it. I think in Ranjit's practice, again, it's a different cohort. He would be seeing it in a different light. For me, it is like I have to see kids every day with allergic problems, and the Montelukast combinations with cetirizine, with levocetirizine. So those things are much more frequently encountered. Hence, I'm very guarded about using it.
Okay, that makes sense because as asthma adjunct also, it is losing its position, and the effectiveness also is less spoken about. So I guess if the side effect profile is as rampant as how you are describing, it's better we keep away from it. So Dr. Ranjit, what's your take?
Yeah. In my practice, I don't give more than a month, maximum of a month. I never give more than a month, but I do make it a point to inform the parents that there is such a warning. And if you find any behavioral changes or sleepwalking and those kind of things, to stop it immediately. So they are aware, and usually it's in a situation where it's really very, very severe allergy with asthma background that we give it. Not for any patient with the tonsil adenoids or something like that. So it is generally for patients who have a background of urticaria or asthma associated with adenotonsillar hypertrophy. I would generally give it for maximum of a month with a warning. And having said that, in my experience, I probably one or two I have had parents tell me that they were not comfortable and they stopped it, but otherwise not really too many. And as you know, in Bahrain we don't have combination medicines. In India you get Montelukast with levocetirizine, and the combinations are available, and parents and children alike, they use it left and right without doctor's prescriptions. Anytime they have an allergic response, they take a Montelukast with. They don't get plain levocetirizine. Many times they use the Montelukast with
Yeah.
levocetirizine, and it doesn't really cause much as far as I have seen till now. Yeah, that's my experience.
Okay. Regarding sleep hygiene, do you have any recommendations to the pediatricians to counsel parents? Any
General.
typical sleep hygiene changes you want us to counsel our parents as such?
Yeah, so I think there are guidelines of how many hours of sleep each age. There's a criteria. So there are national sleep. There are various sleep guidelines on and WHO guidelines on the number of hours an infant, a toddler, an adolescent, and all this. So all of us should literally have that chart up in our office practice so that parents are also aware. They come and meet you and they see, oh, these many hours of sleep is recommended for a child, right? That's one. It's just not the hours of sleep. So some parents will come, oh, my child sleeps at 12 and gets up the next day at 12. I'm like, when will this child go to school? Right? If you're sleeping for 12 hours and then, you're getting up the next day at 12, right? So we need to know that their circadian rhythm is different from ours. So you and I may sleep at 11, 12. We can be a night owl, but the same doesn't hold true for a toddler or an infant. They need to be in bed by 7:38, right? Literally, and getting a minimum of 10 to 12 hours of sleep. So again, knowing what is the duration of sleep, when is the cutoff, this is the sleep time now. That's one. Second part. The third thing is in infants and toddlers, particularly they're bottle fed kids who are waking up a lot at night. So again, you have to counsel them about how much feed, how late the feeds, the last feed should be of a bottle should be by what time. So again, those are the like because the feeding schedules affect the sleep, right? So those you need to understand. Then the screen time, right? There are WHO guidelines, IAP guidelines. There's so many guidelines on the screen time, right? So a lot of kids are on the screen, and the blue light effect of the screens is not allowing kids to sleep, not allowing them to switch off, and there's a whole change in their circadian rhythm. And hence, again, that part has to emphasize. So in your practice, anybody's practice, first three questions: what time does your child sleep? How many hours does he sleep? Is he waking up frequently at night? And what's the screen time? I think that should be mandatory, written in every thing. I mean, it's just four questions, but it'll give you so much insights. It'll give you amazing insights to a child's pattern. And sleep, as you know, it's not affecting the cognition, memory, mentation, immunity. It is a it. I think your whole life is going to depend on the sleep patterns you set now in childhood. And if we pediatricians are not giving it that much importance, then a parent is obviously going to be as clueless. And a lot of parents these days are working in call centers, right? They come late, they're getting late home. A lot of children are in daycare, they're napping all day, then they come back home, they're not able to sleep. So there are a lot of these things with development, right? Or getting more developed as moving forward, I would say. But these things are impacting our children a lot. And, so many times in practice, we see hyperactive children. All we had to do was fix the OSA. So if they're restless sleep, not sleeping, they're getting up frequently at night, then groggy in the daytime, then sleep in the afternoon, and then they're very active at night and they're not sleeping. And this vicious cycle is very difficult to break, right? And a lot of our adolescent kids, they have again a deranged, they are sleeping later, waking up later, and it's also to do with their hormonal changes, the circadian rhythm changes during adolescent stage. It's called the it's almost like a kind of it's a serious concern now, and world over, even in US, and I think these countries, they're thinking of shifting school timings, especially for these adolescent kids, right? So these are the things that we need to be aware of first, then we can counsel. So sleep hygiene is just nothing but understanding how many hours, what time, what are the screen timings, the food timings, and the naps in the daytime, and how to just get that kind of streamlined.
Okay. Thank you, doctor. Another question, something about nutrition. Somebody is asking about iron in sleep, iron deficiency. Any relevance? Iron deficiency in sleep,
So
nutrition supplementation.
Yeah, so iron deficiency and sleep, I think the biggest uh, thing that we talk about, the biggest condition is restless sleep syndrome and the periodic limb movement disorders. So particularly in the restless leg syndrome, they are known to be iron deficient, and sometimes even with adequate iron level, the ferritin cutoff has to be adequate. I think there's a cutoff of 50 micrograms, and so that has to be set. And so in some of these adolescent kids who have the restless leg or this periodic limb movement disorders, we supplement iron for about 3 to 6 months, and then we see whether there's any change in the symptomatology that they come with, and they do improve with the iron supplement. Yeah, so that is the most common one that we see as far as iron is concerned. Yeah.
Okay, thank you. Dr. Ranjit, when we are referring for adenoidectomy, now we know there is after adenoidectomy, post adenoidectomy OSA. So as pediatricians, are there any predictors that you would ask us to counsel them before referring, and a possibility of this post adenoidectomy OSA? We can help you in counseling also as a proactive measure. So can you just give us some tips so that works as a team?
That's a very, very relevant and a good question, because you see the approach is this: when we take a consent for any procedure in any specialty, we explain the risks and complications, and at least the most common ones. And the patients really respect us when we are able to predict with reasonable, accuracy of what we expect. The same thing holds true for this situation of adenotonsillectomy referrals. So when you see the phenotypes that I mentioned, especially obesity, the high arch palate, the crowding of teeth, syndromic children, all that, we can tell with reasonable degree of accuracy that just or people with very bad allergy, for example. So we can tell with a reasonable degree of accuracy that just fixing the adenoids and tonsils are not likely going to give a full-fledged solution. They will need additional help, like continuing on steroid nasal sprays on a seasonal basis for allergy control, people with very severe allergy, biologics if required. And I want to highlight the importance of an orthodontist referral. So we can counsel about this, the high arch palate and the tongue falling back thing, so that they will be alert enough. Parents are definitely more than willing to do anything for their children. And when we tell them that this is also contributing to the problem, they'll be more than willing to do the adjunctive treatment with the orthodontist, which really helps. The widening of the maxilla makes a huge difference when it comes to the tongue base falling back and nasal airway and so on. So it makes a huge difference. So it's something that can be picked up. The reason I put that phenotype slide 3 times is so that everybody knows that it's not just the adenoids and tonsils that we're speaking about. We have to look at that phenotype, and if they have these phenotypes, and you must warn the parents that there are multiple things playing in contributing to the snoring and the sleep apnea, and it requires multidisciplinary care.
Thank you very much, Dr. Ilin and Dr. Ranjit. It was a very nice discussion, follow-up of a very nice presentation from both of you. Thank you very much. It was very informative, and it served the purpose of the theme that we had scheduled for discussion. I would like to tell the audience that some of you who have not received the CME certificate, you please mail the same contact person. You probably have not given your ID or name in the registration. That's why you probably would not have received. I'll follow it up on that also. And as I said, we have reached the 12th webinar, which is already 1 year anniversary. We are taking a break for the next month. We will keep you updated about our schedule of IAP, AMH, CMEs from the new year 2026. So we will keep you posted on this. Thank you very much. The audience and the response have been very encouraging. We started with a very small number of 30 odd delegates participating. We have reached 250 at any session every monthly. And they've all been high quality CMEs, and we have got very good feedback from the audience, not just from Bahrain and India, it's across the globe. Thank you very much. Thank you. I'll see if Dr. Mohammed Salman is there. It is a ritual that he gives the vote of thanks if he's around. I invite Dr. Mohammed
Yes,
Salman,
Doctor.
please.
I
Vote of
would like
thanks
to,
from you. And
yeah, it is really a remarkable day today that we are finishing a 1 year free webinar and the cooperation between the Indian Academy of Pediatric and the AMH, and also the other speakers from Bahrain. And I think this year was a very fruitful year. Most of the lectures and the presentation was very successful, and we received a very good feedback from all the, not only from Bahrain. Our audience are from the region and from so many countries. And I think this is a good experience, and it may be the first time that this such collaboration is continue for 1 year. I'm sure you and the team from the Indian Academy and all the eminent speakers that join us, make this webinar successful. And I would like to congratulate all the speakers and the team and also the audience. As you say, we're starting with a very small number of the audience, but every month we are touching more than 200 attendees, and I think this is a good achievement. We're planning to have next year a conference in which we are rub all the webinars and all the speakers, and it can be also an opportunity for physical and networking for all the people from the professional from the Indian Academy Pediatric and also from the region here in Bahrain. We are looking for the next year, and sure we will have again a successful program for the next year.
Thank you, Dr. Mohammed Salman. That brings us to the conclusion of the session. The details of the IAP AMH symposium that is planned for February will be discussed with you all, as well as we would count on the IAP speakers to contribute also. So we will discuss further about this after we have got more inkling about our sessions. Okay, thanks a lot, and good night, and see you in the next session, which is probably January. Thank you.
Thank you.
Bye, everybody.
Thank you very much. Thank you very much, Dr. Vanitha. I thought you would cut a virtual cake today.
Oh, we would do that in the next year. A real cake. Okay.
All right.
Thank you very
Thank you
much.
very much. Thank
Bye-bye.
you, Dr. Ilin.
Bye, Dr. Ilin.
you.
Bye.
Thank you. Thank
Thank
you.
you.
Bye.
باشه